Reducing bias and stigma towards patients with a substance use disorder is our episode topic. My guest is Kory Scheideman, a registered nurse and clinical nurse manager of the University of Colorado Health Harmony Freestanding Emergency Department. So let's get started.
Welcome to the BRG Nurse Executive Podcast. BRG is a global consulting firm that helps organizations in disputes and investigations, corporate finance, and performance improvement and advisory. BRG's healthcare performance improvement practice offers multidisciplinary services to healthcare organizations. We focus on implementation with innovative, independent, and data-driven solutions. In the BRG Nurse Executive Podcast, we discuss improving patient care by advancing nursing leadership. For more information about BRG, please visit thinkbrg.com. Now here's your host, Nick Chmielewski.
Kory, thank you so much for joining us today.
Thank you. Appreciate it.
Before we get into our episode topic today, can you share a little bit about yourself with our listeners?
I have been an ER nurse for about 18 years in Colorado and currently manage a freestanding emergency department, but I also work with a lot of other emergency departments. I'm excited to be talking about addiction medicine.
How did you get into that area of interest in your clinical practice?
Yeah, that's a funny story, and I really appreciate you asking. For the longest time, I was your standard ED nurse, and I had a patient that came in one day. It was in the middle of the night. I did night shift for 12 years and I was a charge nurse. And a lot of the staff were talking about this patient using slang terms like junkie and drug seeker. Something felt off on it. And then they put on their call light and went in. And this patient was like, I can hear you guys talking about me. Like, I'm here because of a legitimate reason. And I feel you guys don't really care about me. And that just hit me really hard. Fortunately and unfortunately, however you want to see this, as I don't have anybody in my family or friends that have had severe addiction to opiates. And that's really what I've been focusing on. But to truly understand it, I wanted to know more. And so back in 2017, we started recognizing that there was a huge opiate problem in our organization. And one of the providers that I was talking to him about how can we do different things. And I've heard this new program called Alto program, and maybe we should look at that. And so we looked at it and saw the evidence that how successful it was. And so we implemented an alternate for opiate program on the nursing side and the ED provider. And then they also started really trying to reduce the amount of prescriptions and opiates that we were giving in the emergency department, knowing that there was other alternatives that we could do that was better for pain control. And we started digging into that. We got that program going. And then I went to a conference where Dr. Corey Waller was speaking. And I was so inspired by the way that he approached things and talked about medication assisted treatment. I took that back to that same providers. Listen, we got to figure out a different way that we are doing this. And we pulled together a pharmacist, social worker, the provider, and myself. And I helped to lead this team to develop the medication assisted treatment out of the emergency department. And from then on, people have been asking, like, how did you do that? And more, I just dug in and I've learned a ton. There's still a lot I don't know, but what I do know, I want to share. And so that's how I got into this business and why I'm here today.
Awesome. And so, got a little bit about your story and how you got into this area of specialty. Can you talk a little bit more about the incidence, the prevalence, and the history of opioid abuse as it's transpired in the United States in particularly, but over the last several years?
Yeah, definitely. And I want to come out right away and say, I'm not being paid by pharma. This is my financial disclosure out there. These are just some medications that we work with, but I always like to throw that in there that I'm not pharma being a medications or anything like that. This is a whole principle that I want to really talk about. So back in 2017, we had this huge spike. It got even worse through COVID. And then 2023, we actually saw for the first time, we saw in the United States, we saw just over 107,000 drug overdoses. And then that decreased by 3% which in 2022 was 111,000 overdoses. And over 75% are nearing or nearly 81,000 of those drug overdose deaths in 2023 involved in opiate. Again, this was a decrease from 2022, which was 84,000. Opiate related deaths are the number one killer of people less than 45. It's also the number one killer of pregnant women, which is crazy. And it's the number one cause of injury related death, which is more than motor vehicle crashes and gun violence combined. Kind of let that sink in. We focus a lot on those. So I really want that's why one of the other reasons why I'm here doing this. The other thing is addiction and overdose are deadlier than a STEMI at year one. Opioid use disorders got a 9.9 mortality rate at 1 year, and cardiovascular disease has a 7.6 mortality rate. Every day I'm seeing fentanyl overdoses in my communities. And a lot of times it's not the people that you think, it's from other illicit substances that they're lacing with fentanyl, such as methamphetamine, cocaine, and ecstasy. We just had several, unfortunately, high school students in the Denver area that had just recently died and just from a fentanyl overdose. And it's just heartbreaking. One of the things I want to bring up is we're just starting to see some of this, and that's xylazine. It's known as dope or trink. It's a non-opioid sedative that's not approved for human use, as be not surprised. And there's no antidote. Narcan doesn't work on it, and it's now being detected in all sorts of illegal manufactured fentanyl products in the U.S. drug supply. And the studies suggest that xylazine can cause central nervous system depression, respiratory depression, bradycardia, hypotension in humans, chronically may lead to severe withdrawal symptoms, as well as these nasty skin ulcerations that just tear the skin apart. Xylazine is now present in all the states with an increase in 279% from 2019 to 2022. And then another new kid on the block is nitiazine, which is another illegally manufactured opiate. It's also hitting the streets and it's known to be 40 times stronger than fentanyl. So
Do these
um,
drugs show up on tox screens?
they, they don't. That's why it's getting out there and people with substance uses, they want this kind of drug because then they could try to keep their job and from drug screens. But what's really scary is in the emergency department, we're just now getting fentanyl detected screenings and things like that. So it's scary.
So we're really behind the eight ball. But what you mentioned earlier was this concept of the overdoses aren't necessarily the people that you think that they are. And then you talked about people having jobs. So, we're talking about employed individuals in many cases, some
Right.
that may be high functioning professionals that are also using substances. Can you talk a little bit more about that?
Well, a lot of what we're seeing is it's not just people that are dying from these fentanyl overdoses or opiate overdoses. A lot of times the stereotype, and I'll get to this a little bit later. I want to talk about it a little bit more with some DEI, but really we stereotype a lot of people that use drugs as homeless people, and that's not the case. We are seeing all sorts of patients that are coming in. And a lot of times they're employed, but their worlds are coming to an end. And I really want to talk about addiction versus dependence.
What
Um,
is the difference between addiction versus dependence?
so addiction and dependence are totally different entities. Physical dependence is really a physiological phenomenon of tolerance and withdrawal, while addiction really includes a range of social and behavioral impairments that accompany substance use disorder. The DSM-5, if I was to pull that up, it has all these different categories: impaired control, social impairment, risky use, and then each one of those has different criteria. I'm an ER nurse. I like to make things super simple and just break things down into four different C's of addiction. You have to have a loss of control. You're using despite negative consequences. You have a compulsive use, and then you have a cravings. Addiction's not a moral failure or lack of willpower. Genetic factors account for roughly more than 50% of the addictive potential. With age and first exposure, environments, psychological factors, and psychiatric diseases contributing as well. Addiction, it is a chronic and relapsing brain disease. It is the transition from controlled to impulsive and compulsive drug use. It's conceptualized as a reward deficit disorder. So then I asked that question of, are babies really born addicted to opiates? We don't see babies out hustling their diapers for their next fix, right? So it's a hard concept for us to wrap our minds around. I always like to joke I hear people saying, "Oh, I'm addicted to caffeine," and most of us are dependent on caffeine. I know I do. As soon as I don't have my cup of coffee in the morning, I start getting that nasty headache. And that's a dependence. I know that there's some people that said they would choose violence if they don't get their morning Starbies, but most people are just grumpy or have some sort of a physiological problem.
All right, so we've talked a little bit about the difference between addiction and dependence.
Yeah.
And there's this new concept that's floating out there called brain failure. What in the world is brain failure?
Yeah. So it's a totally new concept. So if you have a patient that comes into the emergency department and they have tree trunk legs, they're short of breath with crackly lungs, they're tachycardic, they most likely have, what would you say?
Heart failure?
Yeah. Yeah, exactly right. Congestive heart failure.
Yeah.
You have a patient that comes in that's not urinating, has some sort of fluid retention, they're short of breath, they're confused, they most likely have some sort of a renal failure, right?
Yeah.
Opiate use disorder rewires pathways, kills neurons, and drastically resets our brain homeostasis. The damage opiate use disorder causes to the brain ultimately means that the patient with opiate use disorder has little or no control over his or her need to obtain opiates, engage in virtually any behavior necessary to prevent that withdrawal. In parallel with the neuroanatomical changes seen in the opiate use disorder, patients first use to get high, and then they feel normal, and then to prevent the withdrawal. The loss of cortical neurons seen in opiate use disorder in many cases is permanent. Though dead neurons will not regenerate, several neural pathways may develop similar to collaterals in coronary artery disease. It is more useful to think of addiction as a brain failure. Dopamine and different dopamine, dopaminergic systems are severely affected by drug use, resulting in chronic changes and even death in areas of the brain. So we don't stigmatize patients with diabetes or CHF for these life-changing life choices that they contributed to their disease, nor do we refuse them care or make their care conditional on their behavior. We just treat them. So they did this study and they took three different arms and they had patients. The first arm, they had patients that they didn't give any water for several days. They're symptomatically dehydrated and they placed them in these functional MRIs. They started playing water and music and getting the patient's lips wet. And the part in the brain lit up the relative size of a baseball. Then they took the next group of patients and they didn't let them eat for 5 days. They put them in a functional MRI. They started wafting the smell of food in the MRI, showing the patients like their favorite foods, and their brain lit up the relative size of a basketball. Then they took patients who had been clean for 30, 60, 90, and 180 days, even all the way up to 2 years off of opiates. They put them in a functional MRI and it lit up the relative size of a baseball field when they were asked about the first time they used and the last time they used and how they used. The cravings they saw were worse between 90 and 120 days. So that really tells us that these patients are really willing to do anything they can to
Relive the experience, basically.
relive the experience and
Yeah.
just survive. Like in their mind, they have to do this in order to survive, even more than food and water and basic necessities. There's a concept that's known in just addiction world, chasing the dragon. Dopamine is like the king of what we need to survive. So you need food, water, and shelter, right? And some people talk about you need oxygen and like skin to survive as well. But the other thing that we need is dopamine. It's the thing that wakes us up in the morning. It gets us out of bed. And it's a neurotransmitter that produces and pleasure and motivates us and makes us happy. And we seek out those activities such as eating, having sex, any kind of pleasurable activities. We know that eating great food produces around 100 nanograms of dopamine, and sexual experiences produce around 200 nanograms of dopamine. Again, these are all naturally occurring in our body and they go up and down. The first time we talk about, or the first time someone uses the king of dopamine, which is methamphetamines, that person gets over 1,300 nanograms of dopamine. But the next time that they use, they only get like 1,100. And then it goes down from there. It just keeps, every time they use, it goes down and down. And then over time, drugs replace the normal flow of dopamine because the brain's, I don't have to produce the dopamine anymore. So I'm not gonna. And so they get in this mode where they have to, just to feel anything and just to be motivated to get out of bed, they feel like they have to do this drug because that's how they feel like they have, their brain is being completely rewired.
One of the things that you talked about early when you discussed how you got into this journey on focusing on alternatives to opiate therapy was the stigma that was created, how that patient that could hear everything that was being said
Oh,
was treated. And there's been a lot of focus in the last few years around belongingness, inclusivity, concepts around DE. And I'm just wondering, how does the concepts of substance use disorder relate, or does it relate? How does it fix into this mix of inclusivity and the need to have and manage bias in our clinical practice?
that's really been a big push for me. I recently joined our organization's DEI committee and brought this whole new concept of this patient population that we're missing. They don't trust us as healthcare providers anymore because we've created all sorts of trauma to them. We say, you have to do this, you have to fit in this perfect mold, the exact perfect mold in order for you to get clean. And really taking that step back and coming in from more of a harm reduction approach. I know many of us have been verbally, physically, and emotionally attacked by someone who's been on a substance. And I would hope that talking earlier may give you a better understanding of why these patients have behaved the way they have. And to be very clear, I'm never condoning or discouraging anyone from reporting it to the police or any kind of agencies. As a matter of fact, I really encourage you to do that. Similar to trauma informed care, as healthcare providers, we need to reconcile with ourselves the trauma that we have had inflicted on us. And we also need to reconcile some trauma that we've inflicted onto patients that are seeking care, but we essentially treated them like dirt. And for about 15 years ago, when I was a newer nurse, I would have said that they said that they wanted to leave. I would have been like, go ahead. And now I want to make sure that we're treating everybody fairly and equitably and really including, it's such a different term. A lot of what we do, especially with medication assisted treatments, harm reduction. So people are doing things that are risky behaviors. And we do this every day. Harm reductions can be anything from wearing your seatbelt or wearing a helmet when you ride your bike. Those are harm reduction principles that we're doing and really applying this, meeting our patients where they're at, whether they are there with a substance use disorder, whether they're there for a cardiac arrest or chest pain or mental health disorder. Let's meet our patients where they truly are and include them and really take that DEI approach to this as well.
So you also mentioned earlier talking about the prevalence and incidence and prevalence of addiction, of substance use disorder, and its translation to mortality rates as it compares to STEMIs, as it compares to coronary artery disease. And I would guess, granted, being a nurse, we certainly learned about STEMIs in nursing school. Would hypothesize that management of STEMIs would also be covered in medical school. What
Right.
type of, keeping that in mind and thinking about the analogy, to what extent is substance use disorder and addiction covered in nursing programs and in medical schools nowadays?
I always say I'm experienced. I'm not old. But what I was taught in nursing school was that addiction only happened to bad people and they did it to themselves. And finding out that nursing schools and medical schools are getting way better about doing addiction education, but there's a lot of barriers that schools still face. And only about 18 out of 180 medical schools in the US offer some sort of comprehensive instruction on substance use disorder. It's getting better, But really, I think we need to do a better job of getting message out to our
No
community
kidding. My
and
goodness,
in
18? That's
academia.
it? 18?
18.
Okay.
When they talk people they talk about it, but it's not a very comprehensive instructions. It like I said, it's getting better, but we need to do more.
Why do you think it's so low? 18?
18. I think it's low on this is just speculating, but because I think there's not been a whole lot of people that have raised this. We didn't realize that this was such a big problem in our communities. It's a very taboo thing. In the spirit of going back to DEI, patients that we are misgendering, or that's just another thing that we don't really talk about in nursing school all that much. I was actually fortunate enough to really get into DEI in a very early stages because I went to nursing school an hour from Trinidad, Colorado. And I don't know if about Trinidad's hospital, but they were the first transgender sex reassignment hospital.
Oh.
And in that community, it's so just widely accepted that it's very interesting that they really talked about that, but they never talked about addiction. They just said people that use drugs are bad people. We just get them out. And we're doing a lot better job of recognizing DEI. But I feel like this patient population is really just off. And that's my big message is we need to include everybody. And this is a big group that we're missing. There's
So
also the social determinants of health that are missing from this.
so we've talked a little bit about the prevalence and the incidence of substance abuse disorder and even talked about stigmas and bias and managing that. What are the current treatments that are out there? What's best or leading practice if I'm running a hospital right now
Yeah.
and I've got an emergency department that rolls up to me? What should be done in the ED? What should I be doing in the ambulatory setting? How do I provide the best care to my community, especially those that may have substance use disorder needs?
Yeah. There's all sorts of things that we can do for addiction medicine. Specifically, I like to really focus on the opiate just because significant increase in opiate use disorder. The old school thoughts of we're just counseling and abstinence alone were enough, but patients who only get counseling only get 5 to 15% staying off of the opiates for up to 90 days. That's our benchmark is around 90 days. To once we get them past that 90 days, their success rate starts to get better. Opiate use addiction does not respond the same way as treatments as alcoholism. Abstinence-based therapies, they just don't work. 95% have some sort of reoccurrence of symptoms. Notice I didn't say relapse. That's just such a better word as the reoccurrence of symptoms. And then 12-step programs have a less than 5% sobriety rate at 1 year. And when treating those opiate use disorder, when you use medication assisted treatment, it boosts the success rates anywhere between 60 and 90%. But medication assisted treatment it's a long-term program. There's a high rate of failure with short-term detox approaches. Patients with opiate addiction need 1.5 to 2 years to reestablish their normal dopamine levels. When we talked about that earlier, it takes that long. And most of the time, we expect years of medication of treatment, if not lifelong treatment. If a patient comes with medication assisted treatment, we start them on medication. We truly need to make sure that we treat them very similar that we do with like diabetes or hypertension. Like diabetics that come in, a newly diagnosed diabetic would go, well, if you eat and do better when they're a type 1 diabetic, that doesn't really work. So, really, this becomes a chronic illness. Successful weaning off opiates for the long term, not just detoxing, is a slow and gradual process. If you do rapid detox, a lot of times there's an increased mortality rate that we see earlier. And we have three different kind of medications that we do for medication assisted treatment. The first one is buprenorphine or Suboxone, and Suboxone is the brand name. Buprenorphine is a generic, and why that is Suboxone also has an naloxone built into it. Methadone is the gold standard that we've used and seen that we've been using from the 1950s. It's a full agonist. Buprenorphine is a partial agonist and it fills most of your receptors. And then naltrexone is an agonist. It's a different medication or Vivitrol, and it completely blocks the receptors. So, why are we offering medication assisted treatments in the emergency department instead of just referring them out? Patients started on Suboxone or buprenorphine in the ED are twice more likely to stay on treatment at 30 days when compared to those who are just given a referral.
I'm sorry, can you say that again?
Yeah,
Not because the audio wasn't bad, but because I just my that that is telling, right?
right. Yeah. So patients started on Suboxone while in the emergency department are twice more likely to stay in treatment at 30 days when compared to those who are just given a referral. So if a patient comes in and we just give them a referral, essentially, their chances of being successfully getting off of that medication or drug is significantly decreased compared to if we started with them in the emergency department. They did the study back in 2015 and they had three different arms in the study. The first group had just a screening and referral to treatment. You have opiate use disorder, you should go to detox. 37% of them received treatment only 30 days later. Group B had a screening and then a referral to treatment with a brief sort of intervention to talk about their opiate use disorder. And that yielded about a 45% that were still in treatment 30 days out. And then they did the third one, which they screened the patient. They did a brief intervention. Plus, they did an induction onto buprenorphine with a referral to a primary care for a 10-day follow up, along with a 3-day prescription. And that shot up to 78%. So 37% if they do nothing, and 78% if we do this referral with a buprenorphine induction.
So this is kind of similar to what, Dr. Gordon Gillespie talks about with respect to mitigation strategies for workplace violence. He's like, you can't just do one thing. It's the
Right.
totality of having all of these different levers that you need to be pulling to generate greatest best possibility for outcome. I'm
Right.
curious. So
Yeah.
how does this physically work? We know that we need a referral. We know that we need to do a screening. We know that we need to start a patient on treatment while they're in the emergency department.
Yeah.
What's that process in the ED look like? Is there a third person that's consulted that comes in? To what extent is the ED provider being the person that's actually ordering or starting the therapy? Do patients leave with those medications, or are they just leaving with the script that they go and then fill at the pharmacy? Like, how does all of that stuff work operationally?
Yeah. So currently, when we have a patient that comes in, we screen everybody. We do the experts on everybody. So we're screening everybody. And if we screen a patient who is a candidate, the first thing we do is we say, do you want to stop doing what you want to stop doing this drug? And a lot of times, if you ask anybody that has some sort of an addiction, if they want to stop, they say yes. They just don't know how. And so what we do is we say, do you want to stop? And if they say yes, we say, we have a way to help you out. We have a way that we can help you. Currently in the emergency department that we just started doing something where we brought a peer in, and I know that this is pretty common in a lot of places on the East Coast, but we partnered with one of our community organizations, and we brought in a peer as well to really just talk to the patient and really ask them like what want their recovery to look and let them know that we have this treatment. And so if we identify a patient that is a candidate to do an induction on buprenorphine, the next thing we do is we screen to make sure that there's no kind of any contraindications or anything like that. And then what we do next is we do what's called a COW score. It's a clinical opiate withdrawal score. And we score them to find out how bad that this patient is in withdrawal. And we need this patient to be in withdrawal because buprenorphine is a agonist antagonist. And so if we give them a medication, it's going to put them in a worse withdrawal. And so typically we want our patients to be in withdrawal in a score of an 8 on that clinical opiate withdrawal score or COW score in order for them to let the buprenorphine essentially go in and cover all those receptors.
Is that 8 or greater or 8 or less or
8 or more, I'm sorry, yep,
okay.
8 or more, so they have to have at least 8, and then we assess them. So we assess them about 30 minutes later. It's a sublingual dose, and interesting, Suboxone or buprenorphine has a really high bioavailability in the oral mucosa, and that's why naloxone is added to it because it does not have a great bioavailability orally. Instead, what that does is it prevents patients from taking that and like crushing it up and trying to snort it or inject it, or it has a because of the bioavailability. It's really fascinating how that works. But we reassess that patient and we check their COW score. Sometimes it goes up. And if it goes up, we actually give them more buprenorphine. And then typically that goes down. An average is about 16 milligrams of buprenorphine. And that's like an average daily. Later on, they will take that patient and typically they'll break that 16 milligrams over 2 to 3 times a day. Sometimes patients are able to do just once a day, and just monitoring them closely. But what that does is it starts to completely clear their mind. They start to lose this fog that they're living in. It reduces their cravings. So now all of a sudden they don't have these cravings. When I talked about those cravings before and the physical withdrawal symptoms that they have start to significantly decrease. And it's so interesting to give these patients the buprenorphine and really watch them. And they're like, oh my God, like a whole new person. And they're miserable. And all of a sudden they can start to think clear. They no longer have this craving and they can start to think about more than just that drug, which is really important because then they can start thinking about other basic hierarchy of, okay, now I should eat and now I should start focusing on my job or getting a job, housing, not in those particular orders, truly starting to change on contributing to society again is really what we want. The other thing that's really interesting is we've noticed since we've been doing this, if you've been working in the emergency department, we have those same patients that come back day after day.
Yeah.
And even if we cut them off, they keep coming back. And what we've found is when we give these patients, we do an induction on buprenorphine, these patients aren't coming back anymore. They're, or they're not coming back for that.
What I hear you saying
Like
is
that
you're decreasing high utilizers.
correct. And you know what? At first, when we first did this, I first rolled this program out, I had a lot of naysayer docs. They're like, oh, and nursing staff too. These patients are just going to keep coming back. Oh, great. Now we're going to have a line out the door for these people coming in to get treatment. If they did that, wouldn't that would be a good thing, right? That we have a treatment for them. But these patients aren't doing that. They do come in and the words are getting out there. And what I really love about this is our patients are starting to trust us again. I talked about bringing in that peer. That's another piece of that.
And that's a third party, a third entity that you have
Cor-
contracted with, and that group has peers that are coming in when they're contacted. Is that an appropriate way of describing that?
Correct. Yeah. So in actuality, we do that, but we also have some that come in and they just stage and are eat. They're a third party. They're not part of our hospital. I know there's some hospitals that actually are hiring these third party patients to come in, but
How long does a patient's visit last when you're doing an induction? So from the time the
yeah,
patient comes in to the time that they're leaving, not only with having the induction completed, but also now either they've got a referral or they even have an appointment scheduled. How
right.
how long does that take?
It all depends, but for the most part, these patients come in, we see them, we triage them, and we do the induction. And an induction really takes anywhere between 30 to an hour and a half at the most.
And that's after being seen by a peer where they've established that this person really does want help and that there's no
Right.
contraindications and everything. Okay.
Correct. So a lot of times our length of stay times for these patients are right around 120 to about 120 minutes, really is what we're talking about.
That's not bad.
And it's really not that bad because a lot of times prior to that, we'd have these patients that came in and they said, I want to go to detox. And so we have
And
to
then you're waiting for a
commit
bed available, you're waiting to figure out where they're gonna place them, you're waiting for all of these other things, and they just sit in your ED versus
hours.
now you have an ability to either bring in someone to talk to them or provide the care, and then it is so how quickly are these patients getting the follow-up access, and what degree
Right.
of reliability do you have that when they're walking out the door, they're seeing their ongoing care provider for this process the next day, the next week, like, how
Right.
reliable is that?
So when we were developing it, one of the big key things was how do we get these patients the next day follow up? When we first started it, we still had the X waiver. Nobody had that. And we had to refer them to a provider that had an X waiver.
What's an X waiver?
An X waiver was a specific training that providers had to have in order to write for buprenorphine or a methadone. So they had to have a specific training. There was only a lot of most of the time it was just toxicology docs and addiction medicine doctors, primary care doctors that had that. It wasn't very prevalent. Our ED docs didn't have it. And so when we first started it, the program, we would just give the patient and we got them a next day appointment with a provider. So we built that community in our area. We had 8 different kind of providers throughout our community that we could get that patient in for a next day appointment. A lot of times now our ED docs are now writing a script for 3 to 7 days until they can get to that provider. But now we have when we first started, we only had 8. Now we have so many out there. It's crazy. So we're
And you
not
said when you first start when did you first start this process? How
yes,
long are we talking about?
2019 is when we first started our
Okay,
medication assisted treatment. As like the pandemic definitely added a degree of difficulty to this.
sure.
And every organization and community in this is different. And that's my big key message. If I had to tell you anything before you start a MAT program, is really get your community partner involved. And they're out there and they're making big progresses or big strides in this community. And that was our success rate. If we have shown that if we can get a patient in with this group, they have a 90+% success rate. They're not coming back. The other really cool thing is that group that we refer to as a hub and spoke model. So they're almost like a dispatch center. So we refer to them and they're the ones that are providing the peer. So we refer to them and then they say, I have a next day appointment with this doctor X and X. Here's the address. Do you need help with transportation? We can
Oh,
help with
wow. I'll
transportation.
even take care of that.
Do you need help with housing? We have partners that we can get you in with housing. Do you need feminine products? Do you need jobs? We have all sorts of assistance with that as well. So they essentially scoop these patients up that have been just falling through the cracks, literally falling through the cracks. We're scooping them up and we're putting them with this group that can help them out. And I think that's the other big key piece of it.
If I'm a chief nursing officer in my health system right now and I'm thinking, "This sounds like a great idea. I wanna learn more,
Mhm.
and I don't know where to start. Where should I go?"
Here in Colorado specifically, one of the places that I went to that really helped was our Colorado Hospital Association group. SAMHSA has all sorts of programs out there as well. I'm trying to think of really working with your toxicology groups. If you don't have that, I live in Colorado. And Colorado is we have urban, rural, city, like we have suburbia, we have all sorts of not groups, but communities that we work with. And every one is slightly different, but there are groups out there every single day. you just have to look for them. I don't know that I had this magic go to this organization or not, but I would say SAMHSA is probably one of the biggest places that I went. I learned a lot about medication assisted treatment in the emergency department as well.
So are there any like new or emerging things that you're doing? What's the next step for you in your care in your emergency department?
We just started last month is we're actually using naltrexone. You remember I talked about the three different medications. So we have buprenorphine, we have methadone, and naltrexone is almost like a long-term Narcan, if you want to consider it that.
Okay.
So, but what it does, it also helps with the cravings. That works well. We're actually starting to use that with alcohol use disorder patients in its unique specialty or not specialty, a unique situation and how we can apply this. And what we do, and that's a oral, it comes in a IM shot. It also comes orally. And what we're doing with these patients is we tell patients an hour before you start drinking alcohol, you take this medication, naltrexone before. And what it does is it tells the brain, it takes away the euphoria, completely blocks the euphoria that patients were taking or using alcohol. And now all they feel is dizzy. They feel nauseated. They get the effects of the alcohol, but they don't get the
I
euphoria from it.
Yeah.
And that over time, they start to go, I don't like this. Like the alcohol's not doing it for me, but it also takes away that craving. So they're not seeking that craving.
Any closing thoughts as we wrap up this episode?
Carry naloxone. I carry it on me. I have it on me. I have it in my car. My kids have it. I have two kids that are in college. I gave it to them. It's in my house. My 11-year-old knows where it's at. Everybody knows. I don't know anybody personally that's using, but you never know where you're going to be and when you're going to be. And it's such a simple, easy, quick thing. And it's a harm reduction. It's not going to hurt anybody if you gave it. We're going to help anyways, or at least I would hope we would help someone. There's an abundance of it out there. Just ask for it. Look it up. There's the naloxone project out there that's doing everything they can to give it to anybody that's at risk, whether they want to take medications or not. We give it to all of our buprenorphine induction patients or medication assisted treatment patients. Maybe not just for them, but sometimes they might be in that situation where they do have a reoccurrence of symptoms, or they have a friend that maybe also has that could use it as well. So carry naloxone.
Reducing bias and stigma towards patients with substance use disorder has been our episode topic, but frankly, we've spent quite a bit of time talking about medication assisted treatment and why you should put it in your emergency department within your health system. Kory Scheideman, thank you so much for taking the time today. Greatly appreciate it.
Thanks, Ed.
You've been listening to the BRG Nurse Executive Podcast, which focuses on improving patient care by advancing nursing leadership. The views and opinions expressed in this podcast are those of the host and podcast guest and do not necessarily reflect the opinions, position, or policy of the guest employer, Berkeley Research Group, or their other respective employees and affiliates.